The FDA approval of Madrigal's thyroid hormone receptor beta agonist ushered a new era in the management of patients of metabolic dysfunction-Steatohepatitis, and for the first time, approved treatment is available for these patients, for treatment of these patients, which is a tremendous milestone on the prolonged and rather difficult road for drug development for patients with MASH. We are delighted that Dr. Rebecca Taup, the Chief Medical Officer and President of R&D of Madrigal, is in the audience, together with members of her team. So that gives us the opportunity to congratulate the Madrigal team for that historic achievement. So congratulations to the Madrigal team. HistoIndex, I would say, contributed to the drug development, the Rezdiffra development, because of established partnership with Madrigal, and that was involved in exploratory analysis of the phase 2, phase 3 data with Resmetirom, which provided some very useful and new insights into the mechanism of action and the location of the changes in the liver lobule. And this partnership between HistoIndex and Madrigal is a good example how AI-powered tools can facilitate drug development, can bring effective therapies to patients with NASH. I also would like to highlight that data with second harmonic generation microscopy involved in the analysis of Resmetirom phase 3 trials will be presented by Jorn Schattenbeck on Friday, 7th of June. So you can hear more about the results of this analysis. As I said, the second part is the discussion with the expert panel, and this is a continuation of the webcast which was published on 30th of May. And the topic of the discussion were twofold. This was the evolving role of liver biopsies in the new era post the first drug approval in MASH. And the aim was to discuss the two settings. Firstly, the role of liver biopsies in the clinical management of patients with metabolic dysfunction, steatotic liver disease in the real-world evidence. This is the routine clinical practice on one hand. And secondly, the use of liver biopsies in clinical trials for drug development for MASH. The webcast involved a distinguished panel involving Arun Sanyal, David Kleiner, and Tim Kendall, who were discussing these topics. In the next few slides, I will briefly summarize the key takeaways from the webcast in case you haven't seen it, and that will give us the background and the context for the questions with the live discussion later on. So the first takeaway was that while non-invasive tests hold many promises for the near future, there is currently no single or composite set of NITs that can be used as a precision tool for MASH patients' diagnosis or monitoring. The second takeaway was that liver biopsy remains a key diagnostic approach in the following scenarios. Firstly, to confirm the MASH diagnosis when there is discrepancy in the NITs or the results are discordant. Secondly, to detect or exclude patients with intermediate and high risk, which is according to the current guidelines. To exclude comorbidities, predict long-term clinical outcomes, and also to assess treatment response and futility of current trials. Just as a brief reminder, these are the current guidelines that we have. On the left is the AGA guidelines, and I would like to draw your attention to the part where it says that when the NITs are discordant and there is concern for concomitant alternative diagnosis, then one should consider a liver biopsy for defining the cases where there is clinical suspicion for fatty liver disease. In the ASLD guidelines, similarly, when there is clinical suspicion of intermediate and high risk, then liver biopsy should be considered, especially for excluding patients with cirrhosis and better definition of the diagnosis. With respect to the role of the liver biopsies in future clinical trials, these were the key points. Firstly, that clinical trial endpoints have not changed, and with the need for histology assessment. Secondly, that biopsy has a role in the development of combination therapies to tease out the impact on fibrosis and inflammatory activity from different mechanism of action of the components of the combination and their spatial location within the zones of the liver lobule. There is potential of digital pathology and AI to personalize the treatment options for patients, and that hopefully we can hear more on that last topic during the discussion. So with that, I would like to open the discussion, and please feel free to ask any question. Actually, I will start with one question which came after the webcast, and this is addressed to Dr. Sanyal. In the clinical management of MASH patients, if NITs readout show no improvement or no worsening during therapy, what would be the next course of action? Will you keep the patient on the same therapy for a bit longer, or will you consider a liver biopsy to reassess diagnosis or treatment response?
I think the decision has to be made on a case-by-case basis. If you have somebody who I believe is closer to stage, assuming this is a patient who's just being followed with NITs, if they are who I think is probably closer to the F2 rather than the F3, F4 interface, they're closer to the F2, F1 interface. Stability is not necessarily a bad thing. So personally, I'm not going to outgo longer before changing course in that type of patient and let them declare themselves a little bit before I change course. On the other hand, if somebody is right at that interface of F3, F4, where I'm more worried about progression into cirrhosis, I see the platelet count beginning to drift a little bit, I may be more inclined to then reassess the patient. The challenge, so I think what we don't have a lot of experience with, because the only, at least from my personal perspective, the patients I've followed on the approved drug are the patients that we put into the trials. And now we're beginning to just get some experience, beginning to put people on the drug outside of a trial setting. But once we have lots of patients like this, will there be populations where, say, the liver fat gets better, but the enzymes don't, or vice versa? There's some discordance between the enzymes and because those are the two things that I'm thinking that will be following initially. In that setting, or the liver stiffness does, something weird happens with liver stiffness along the way. There might be a few cases like that. So I think in that type of setting, I still think there is a potential role for histology. The challenge, of course, is if you don't have a baseline and you're just biopsying somebody down the road on treatment, you don't know where they started. And so personally, I think in my academic practice, I will still have some role for histology. We're not going to quite abandon it while we continue to generate data on NITs. We know the world is moving towards NITs. There's a ASLD guidance document that is in the works on how to use NIT-based therapy, how to use NITs to manage patients on Resmetirom, but with the caveat that it may not be an exact fit for 100% of the patients, that there would still be some patients where there may be a need for histology.
Jonathan, what is the European perspective on that question?
Well, just before that, I just wanted to follow up on something that Arun said. This is something I struggle with a bit as a clinician, because in patients with advanced fibrosis or cirrhosis, non-progression is also important, stability. So, we know it's quite difficult to regress fibrosis, but, lack of progression to cirrhosis or lack of decompensation is also important, and that's difficult to prove. And also some of these studies go on for a long time. So when do you decide that something's not working or not? And then I'm also struck by your Tropifixor study, where when you re-examine the histology, which was negative, actually, when you use a more sensitive technology, you can actually see that there are effects. So maybe we're just not looking at the right things.
And that's not only the single example, but many other drugs have shown that if you look more sensitive way and more detailed analysis, you can see significant changes that were actually missed by the conventional assessment. Mark, you're very active today, Mark.
Just showing you that I'm awake, Nikolai. It's okay. I mean, when we were junior doctors, we were taught, don't do a test and that's going to change the management of the patient. You're incurring potential risk, you're incurring, in the States anyway, there's cost involved. But actually, the patient often wants to know a bit more about, what's going on, how serious their disease is, what the prognosis might be. And, there's a limit to what we can achieve with NITs. But the key selling point of this new technology is what extra prognostic information can we get that would justify this to the patient, the patient would be demanding to know.
I do want to make one clarification that I think the NITs are getting pretty good at predicting long-term clinical outcomes and are at least as good as histology. I think the newer data that's coming out, and you'll see more coming out later this year also. Yeah, among others.
Rebecca.
Yeah, so thank you. I just wanted to comment, we do have a late-breaking abstract that will show, I think on Friday, looking at some of these decompensated related features and in patients treated with Resmetirom, the Q fibrosis features specifically. And I think, so 2 comments I wanted to make about this. The point was that you can see effects that may not translate into so-called one-stage, improvement in fibrosis, and certainly less, it would translate also into less worsening or et cetera. The other thing is comparing it, which this talk will also do, comparing those features to MRE, FibroScan, Pro-C3 or /ELF, and some other non-invasives. And I just want to throw out the comment on serial liver stiffness and how one can get a very good group mean, right? A group mean effect. But because of, especially with FibroScan, the variability around each measurement, when you only have 2 measurements and maybe the baseline is, fluctuating plus or minus 30% in an individual patient, what can you really tell? And how can you reconcile? So for Arun and anyone else up there, how can you reconcile that kind of change in an individual patient as compared with actually having serial biopsies?
I think Becky, there's excellent, they're really very important points. The FibroScan, no matter which biomarker you use, if you're going to use it serially over time, to assess change, first you have to be sure that whatever difference you're measuring is not simply methodological, and you have to rise above the noise. And so unfortunately, there is still a lot of, there's the 30%, 35%, and that paper was just accepted in radiology, showing the different day, different operator coefficient of variance. So for FibroScan, we're stuck with that unless there are approaches to reduce the noise. And I know that we talk about 3 hours of fasting and, how many procedures you can do before you get certified to be able to do that independently. And I know at my center, we have a much higher threshold for allowing, it's run by pretty much 90% of the FibroScans are done by nurses, but they have to do at least 100 under supervision before we'll allow them to just do them independently. And so that I know a lot of centers have just a handful of, the companies are proposing that you don't need to do that many. But I don't know, maybe doing more gets you over that learning curve. Number two, do you really need to is 3 hours really sufficient? Because to my knowledge, we really don't know the hepatic blood flow changes after a meal in a NASH population where some of them are diabetic. The food is being released from the stomach to the intestine at various rates, which may alter blood flow. Also, with varying degrees of fibrosis in the liver, is for the exact same meal composition, will you get differential blood flow changes which would affect the liver stiffness? And I wonder how much of the noise is because of some of that. And maybe we do need to go longer, and that might reduce the noise. But other than that, I don't see how we really can. If you only have a 10% change, you can't really interpret it. So we have moved to actually telling patients you're in the green zone, orange zone, or red zone, traffic light approach, rather than telling them you have F2, F3. Because I think it's a joke to tell anybody based on elastography their precise histologic stage.
One other question which came after the webcast, this is directed to Tim Kendall from his pathology expertise. On the webcast, you talked about the use of AI to extract more information from the biopsies that cannot be observed by the human eye. What kind of histological information can one extract, and how this can be used?
So when we're looking at a slide, just as pathologists or as humans, we see patterns, we see colors, and we ascribe some meaning to that. But it's very difficult to put any form of quantification on that at all. I mean, we try, and the F stages kind of attempt to do that. But if we're looking at fibrosis, for example, we use PSR in Edinburgh. I can see what's red, and I can see what things are linked up. I can see if it's sinusoidal fibrosis or big, thick bands, but not much more discrimination than that. And if we've got imaging, the SHG imaging or AI using stained sections, is able to find and quantify far more features. So there are 184 features from SHG, and the SHG features have a meaning. There's a description of what they actually mean. It's intersections, crossings, amounts, distribution. So you're able to get a much more granular feel for exactly. It's not quite, but it's almost you can feel where the fibers are, what's linking, what's interacting, where it's interacting particularly, and it can put a number on that, and that allows smaller changes to be then followed, which I think is what we're all aiming to do. Because we were talking about F stage just then, and it's linked to what I was just saying. I'll make a comment about F3, and I hope this doesn't come across as a pathologist being defensive about our poor suboptimal performance. I don't know how Dean described this. I'm slightly concerned.
There are enough pathologists in the audience to defend you. Don't worry.
I'm slightly concerned if I put my slide on the other way around on the stage, I'm going to give you a different diagnosis, which is something I hadn't thought of before. But we might get a 20 millimeter core, it's a good sized core, and there's portal fibrosis and central fibrosis, and there's fingers of sinusoidal fibrosis, and they're nearly touching in one place. So one day, one of us might say, well, that's a bridge, that's F3. Another day, or others would say, no, it's not quite touching, it's only F2. And we've discussed this at some length. We've discussed this with David Kleiner at some length. These are important distinctions. But some days we might say that patient has F3. But on the other hand, there's another patient with lots of bridging all over the place and early nodules. Not quite cirrhosis for some of us, still F3. I don't believe that those two patients, the one that's just nudging into F3 and the one that on another day we could call cirrhosis, are the same. So any discrimination we have within that, however that's done, non-invasive tests, AI on stained sections, AI using unstained sections, serum markers, anything that can help, kind of delineate reversibility, delineate prognosis, delineate treatment, potential response within those stages are something that I would, that's what I want, get more from that tissue.
And I guess your clinician would be happier to receive more detailed report and more guidance on.
Yeah, I mean, so in my reports, clinical reports, I'd never use the numbers. I hate scoring. Just spend a lot of time doing it, but I hate it. I use words to paint the picture, and then I show the pictures to give Jonathan and others on the Monday lunchtime.
Do you sit some time together at the microscope with Jonathan or any other clinician and look at the biopsy and discuss it together? Because in the old days, that was what was happening, and that's how we were trained, at least in my generation of hepatology.
Yeah, so some of the hepatologists will come at the instant I get the slide out of the lab and sit and look at it. That's more for the injuries like acute hepatitis. But we bring along every week the cases we've reported that week and have been photographed the various stains because a picture tells 1,000 words. People get if you see enough of it, you get a feel.
Markus Heim from Basel.
I guess one of the main arguments against using liver biopsy is inter and even intra-observer variability or discordance. And the hope of these models is that once they are robustly trained, they would be very reproducible and always predict or give the same results. But now let's say there are other companies who train other AI models. Will we have the same problem, inter-AI variability, or do you predict they will all have the same output?
I suspect, well, you'd have to do it. I don't know if it would even be possible. A head-to-head comparison between them all to see what that shows.
So in Nimble Stage 2, that's a planned analysis where on the same set of slides, well, it won't be the exact same because some will be stained with H&E and others will be used for SHG, etc. But as close as you can get to that, that'll be one analysis that is done. But, I think some of them are asking different questions. The question, it all links back to how the question is framed. If it is the exact same question that is being asked by multiple approaches, then I think that's a legitimate question to say, do they all land at the same place? And that may have to do with the validation of one approach versus another. There are other things that go into it. But if they're asking slightly different questions, then it may not be as important.
I can only share an experience. When I was at Novartis, we did the analysis for the Tropifexor phase 2b trial with HistoIndex and another not to be specified AI company. You get the results, and as Arun said, you get different readouts, different parameters, and you choose the one that serve better the analysis of the data. So one you get only numbers, the other one you get description of anatomical structures, the lobular location, etc. And that's what we decided to go with. They are very different, but they give you different readouts, and you use the one that suit the analysis.
But easy things like quantifying fibrosis. Will you predict two different AI models from two different companies agreed, but they don't agree?
I'd predict they wouldn't be in perfect agreement. That if it's a stain, because I've done my own homebrew versions of this, so far less computationally intensive or clever. But this is a PSR stain section, and you're doing a pixel count. It's the simplest question: how much red is there? Okay, but you zoom in, you zoom in, you zoom in. In Ferris Bueller's Day Off, when they zoom into that pointillist painting, you just get dots at the end of it. You end up with individual pixels, and they are not red; they are a bit pink. So when I'm taking a low power view, I can say, well, that's a scar. I zoom in and it's a little bit of pink. I don't know what that should be. So one classifier might say it was a scar pixel, and does it say it's not? But there is no right answer.
I think there could be a difference between stained and unstained because there's still that potential variability of staining. So I'd imagine that they would be different, but AI models trained on, I don't know, MASMs or PSR may be more consistent. That would be my hunch, but I'm not sure.
Yes, please.
Yes, this question is referring back to the serial measurements using, for example, transient elastography and the variability, and now doing potentially a serial assessment by histology. And of course, you are reducing the variability on the intra and inter-observer level. But when you increase the granularity of your model, continuous scores, for example, for fibrosis, I think one needs also then to consider the spatial heterogeneity. So actually you get a more granular assessment, but that's now also introducing more variability. So is this actually a good way to measure the state of, for example, fibrosis in your patients when it actually gets so granular?
Yeah, I mean, if some days on a 15 millimeter core, you might get only a couple of portal tracks just because of what it's gone through. So if we're saying, as we think, looks like it, the portal features, periportal features, the most important, it just happens not to have caught some, then there'll be an understaging or an underappreciation just based on sampling. In fact, we are doing some work on minimum lengths and minimum widths that should try and at least allow us to say what length of core should give enough information to allow those judgments to be made. At a 15 millimeter core from a 1.5 kilo organ, it's a problem.
Jonathan?
Mine is just to say that by experience, our ability to learn it. What is it, the serial measurement? Two groups at the same time. I would pursue is also quite hard.
Yeah, totally. I struggle a bit outside of a clinical trial with the concept of serial biopsy to measure, natural history. I struggle a little bit with that. I would not trust FibroScan longitudinally for the exact reason that Arun said, the coefficient of variation just too big. I think ELF and some of the MRI measures, MRE or MRI CT1, for instance, got much tighter COV that may be more appropriate to use longitudinally. But yeah, I'm not sure about biopsy. I think you're right. I think it could have significant variability, certainly with conventional assessment.
Although, in defense of elastography, if you do rise above that 30% threshold, it does correlate with progression and clinical outcomes. And I think it's important not to take a either or approach. These are all, we have a armamentarium, and there's no question that in routine practice, the majority of patients will be followed non-invasively. That ship has sailed. I think we should acknowledge that. But I think at the same time to say that is 100% of the patients can be managed 100% of the time with our existing portfolio of NITs also is probably not accurate. There is a role for histology in selected individuals.
We always speak about the disagreement between pathologists, but I think that the adequacy of the liver biopsy and the quality of the liver biopsy is one major issue. And for instance, are there any papers that look or evaluate the disagreement between pathologists according to the length of the biopsy and the severity of the disease? Because if you have a small biopsy, but very severe, we will all agree. But if we have a longer biopsy with mild disease, difficult to say yes, balloon, and so. So I think we do not take into account enough the length of the biopsy according to the grade of the disease.
I think there is an ongoing work, by the way, from HistoIndex on the variability of the AI assessment according to the size of the biopsy and defining what is the minimum length width of the section of the biopsy in order to generate reliable and reproducible information. At least on the AI side, this is on progress. There is one poster later during the meeting.
Yeah, independent of histoindex, we had published in 2016 or so using second harmonic generated imaging that if you did virtual biopsy, if you took your biopsy core and then redid the analysis using smaller and smaller sections, up to about 1 centimeter, you could maintain the fidelity. But once the biopsy was less than 1 centimeter, then sort of there was a substantial deterioration in the quality of the readout. And I don't know if your data so far is similar or different.
Yeah. It's not like 6.
For us, it was over once. We could go down to about 1 centimeter, but up below 1 centimeter, there was a major, it's like a sudden falling off a cliff in terms of the quality, variability in the readout.
I have another question going maybe a little bit away from the biopsy. So we want to go to NITs, and most NITs are continuous parameters where we are comparing them always still with event yes, no, or biopsy F1, 2, 3, 4. So getting into the quantitative assessment, the continuous assessment of the biopsy, can we improve the NIT or the understanding of the NIT and to implement them? So just a general question. And then also in regards, if I have, for example, a fibrogenesis marker like ELF or ProC3, should I compare it with just certain features of the AI reading?
So I think the NITs increasingly are going to be linked directly to clinical outcomes measures. And to be able to say that, if your liver stiffness changes from X to Y, this is what it means in terms of your probability of having a liver outcome. And it's going to be less linked to histology, as that's where the field is sort of generally moving towards. It depends on the specific marker. So if you have a marker of fibrogenic activity, which is different than lipotoxic injury and ALT, there may be, I guess you'd have to do the analysis too. And I think the large clinical trials are the best place where multiple biomarkers are being tested along with elastography and histology and linked to clinical outcomes. So I think in that kind of setting, it would show that which of these would make sort of sense. But there has to be some biological reason to say this is a good comparative, we're going to correlate this with this. So I think the biological plausibility will have to be an important consideration in picking the pair.
It's good to know which of the SHG features predict decompensation and mortality, but how long before we know which of those features also predict response either to lifestyle or drug therapy? Will precision medicine really come into play here?
Yeah, possibly. I think Becky's just left, but I think the Madrigal data.
Speak freely.
I think the Madrigal data using the histoindex features the exact same features that we've been looking at in the Madrigal patients, looking at responders, non-responders. And once you look at that further with events and layer onto that NIT correlations, I think that's where we may be able to start unpicking this a bit further. Because you're absolutely right. It's a very fair question. Which it's not just can we identify these features that we think are predictive, but can they be modulated? Do they change? And I think that's the thing. So I believe there's a presentation 15 minutes before Tim's in a different location, so you might have to run between the two.
I have one question to Dean as an honorary member of the panel, and the results that Jonathan presented in steatocyte cohort are very interesting. They link for the first time the histological findings with clinical outcomes, but it would be very nice to replicate that or enhance that in another longitudinal cohort and sort of validation of the prediction
the significance of the individual parameters, are there any plans, are there any studies that will similarly ask the questions in longitudinal cohorts for relation to outcomes?
Yes. So, yes, we are working on that. I think we're going to have more papers, more data coming out this year and the following year. And these are all the important questions.
I agree with the comment around the need for a broader scale of grading, that the cases that are the cutoffs between F2, F3, F3, F4, there's so much variability, and the continued bucketing of patients into these 5 buckets as opposed to using a more graded 0 to 100 scale really makes a big difference, or the not doing that creates a lot of issues in evaluating the data, because there are great differences in patients who are low or high in any of these buckets, and continuing to perpetuate data using those buckets really makes it difficult to evaluate how the patient's doing and the effect of the different drugs that we're treating them with. So anything that helps us move away from that, I think, really is a huge benefit.
No, I completely agree with that, and that agrees with what Tim was saying. I just had another question, if there's time. This is probably to Arun and maybe Dean as well. Where the FDA stand at the minute with the potential use of AI, digital pathology metrics for treatment response in pharmaceutical trials? Is there possibility in the future that they could either complement or supplant current?
I think the door is opening in phase 2 trials. For sure, I think they are now more open to using AI-based. They have not quite made it there for phase 3, but certainly for phase 2. And I know there's at least one, isn't Regeneron have a phase 2 trial where the primary histologic analysis is with second harmonic-based imaging. So I think it's coming.
Thank
you. And one news is our previous meeting with FDA on our biomarker program application. So I think to our surprise, more than 20 of them turned up in our meeting. Okay, because normally we expect like 7 to 10. So what happened is actually people from different teams all come to our discussion, and they are well aware of our work in AI, and they are I think they are very open. And the data we show them is very encouraging. So I think that's good news. We just need to give them more data. Like what we showed today, we need to show additional validation and even better data from trials. So these are the data we think can help to convince them.
Thank you. One other point that was discussed on the webcast and was pointed out in the takeaways is the role and the value of liver biopsy in assessing combination therapies for MASH, and in particular to try to dissect the individual impact of different components, whether this is mainly on the fibrosis side or the inflammatory side, or now on the ballooning side. Arun, can you expand a little bit on that? How do you see in future combination trials, which is still our aim, I guess, to build a more effective therapy for MASH, to use the biopsy in analyzing the combination approaches? Yeah, the current combination trials that are publicly, that there's public knowledge about, they're using more or less the same paradigm as we use for monotherapy. It's generally the broad approach is very similar. My concern is as follows. And, long time ago, actually, Brent is here in the room. In the NASH CRN, we have been having these discussions where you have on the x-axis activity and on the y-axis, you have fibrosis. So if you plot that, you have 4 quadrants, right? You have low activity, low fibrosis. You have high activity, high fibrosis. And you can imagine the 2 other quadrants. So if you imagine you're going to take people with high activity and fibrosis for combination therapy, depending on the relative potency of your anti-fibrotic and your anti-metabolic approach, say you're using something with a major anti-fibrotic effect with a major metabolic mechanism of action. Depending on their relative potency, you may end up, ideally you want everybody in the lower left quadrant, that you end up with low activity, low fibrosis. But you may end up with a subpopulation that where the fibrosis got better, activity didn't, or you have activity got better, fibrosis didn't really shift. What's your off-ramp? One thing the NASH field should really learn from inflammatory bowel disease is always think about your off-ramp. What's your exit strategy from your treatment? How long are you going to do? What's the next step? Where do you take the patient from here? And so when you do combinations, what are you going to do with these different populations? Because are their natural history now going to follow the same trajectory, or you've now broken their natural history into 3 different paths? And you may have to then figure out, if you land here, then you go down this path. If you land here, you go down that path. Is there remission induction, remission maintenance, consolidation therapy? You ramp up on one kind of therapy. So it has to be really thought out in more granular detail if we're really going to be successful with combination therapy. And while we would like to use NITs to do everything, I don't think the current NITs, the data, the knowledge base is not quite there to allow us to just do it with NITs. We will still need histology and NITs together in that development process. I don't know, others may disagree, but that's just a personal view.
Dr. Tetri, any comment on your side?
Thanks, Arun, for mentioning that. I presented that at the Liver Forum, that conceptualization of the fibrosis and the disease activity, where we might go from there many years ago. You're absolutely right. We can go in a lot of different directions, and that'll determine where we go next with the next therapy after that, I think. This has been splendid. I just, a question for Dean and the folks at HistoIndex is, you based a lot of the analysis now on the histologic scoring, we hear a lot about the ballooning and all that. But as we get these data sets that have pretty robust outcomes data, will you go back and just be totally blind, unbiased to whatever the routine light microscopy showed, and just say, okay, we have a biopsy here at one point and here at another point, or even baseline. What on those biopsies predicted liver death, or I should say cirrhosis? And what on these biopsies predicted cardiovascular death, if you will? And just ignore ballooning, steatosis, inflammation, everything. Just let machine learning say what predicted it. And I agree, it gets really messy when you start to look at death. We clinicians, we know, we'll see the patient in the ICU had a big MI. Oh, by the way, they're cirrhotic and now they are easily septic and they die. What's the contribution to the MI? What's the contribution to their liver disease? Really impossible to sort out. But given that caveat, can we have the computer figure out what on your data predicts progression of liver disease to cirrhosis? Yes. So I think this is the time we can start doing this. Okay. I think the bottleneck for us previously was the lack of samples. Like recently we did with Resmetirom, we tried to analyze what we call steatosis correction on fibrosis. What happens to liver biopsy when you have a drastic reduction of steatosis? How does that impact fibrosis? So I think these are all the questions we can start asking. And then now with the data we have and the more data we have from other cohorts, we can then answer this question. I think this is the purpose of these opportunities, to work with people to help us to come up with meaningful questions like these ones, so that we can generating meaningful answers. Okay, so to answer your questions, yes, we can now start looking at how these correlate to cirrhosis, because 3 years ago we have hardly any cirrhotic liver biopsy, so now we have plenty more.
So we will have that for the next breakfast meeting, I guess. Yeah.
So, Mark.
You can put a gag on me later.
No. You deserve special thank you for being the #1 contributor to the discussion.
So I love the concept without sounding too cynical from about Arun's comment about an off-ramp, that the pharmaceutical industry might be interested in off-ramp. But moving on.
The pharmaceutical industry in IBD is interested in the
IBD,
off-ramp because the academics held their feet to the fire.
Indeed. My comment, however, was when are we going to start using the technology here to look at a more important liver disease is alcohol-driven?
Very good question. And maybe meta-ALD?
Indeed.
In the middle. Who would like to take this question? I guess, Dean, you are.
I think for us is we follow the samples, availability of the samples. Okay, so I think that's why exciting new topic, new challenge for us all. Yeah, and we look forward to people who are working in this area as well.
So, Mark, go and talk to Dean after the meeting, and then.
I know there are a lot of sponsors over here that I think continued development of, in your drug development process, getting where you have to get histology, using some of these AI-based approaches along with the biomarkers gives us an opportunity to really better understand, how to use all of these technologies. So it's not one or the other. And I hope most of the companies will continue to do so. And that'll really, I think, enhance the field in the long term and position us better, both for precision as well as for combination therapies.
That was a really helpful conversation. It's nice to get everyone's feedback. I guess what we presented today is the first step towards maybe building more sophisticated AI-based models that have predictive value, but it's critical that we validate these findings. So if anyone has got cohorts where they have pathology and either already SHG or an unstained section that we could work with and clinical outcomes, then it'd be fantastic to work with people to help further validate these observations, because I think it's really exciting, but we're only part of the way there at the moment.
But you can also help other longitudinal studies based on your experience, your analysis, and the parameters that you have identified to try to replicate them in other longitudinal cohorts, because you're one step, if not several steps ahead of the others.
What I would like, and I think what we're discussing, is where we have tissue, we should be able to do more with it than just me looking at it and saying what I think, which is what pathology really is. And that might be or will be using stained sections or unstained sections to provide more accuracy in that discrimination in those crude stages. And what we haven't spoken about is we can use the tissue for other things too. And another justification for biopsy, of course, but in the way that we do in cancer, so molecular profiling, cholangiocarcinoma, we'll do we'll do FISH, we'll do sequencing. Tissue, which gives us a diagnosis, and the granularity for fibrosis and these other features, can also be used to augment with other methodologies that we've not discussed.
So I was just reflecting that, having come to these type of meetings in the last 10 years, how much the field has moved. But it takes so much time to generate high quality data. Each of these projects that was presented has taken 2 years plus and a lot of work to actually get there. To build on what Jim just said is, what I would like to be able to better understand is, if I give a drug to 10 people who have exact same histology, same obese BMI, same degree of insulin resistance, some respond, some don't respond, and it's not a compliance issue. That'd be too easy. So there's clearly, under very similar histology, there's biological heterogeneity of the disease. So I would love to see the field move towards being able to give me more molecular answers as to what's driving the disease in a given patient at a given point in time. Because at least we know from animal models that even that changes over time in the same animal. So humans also probably the same thing. So whether that's in the form of a gene chip, spatial transcriptomics, which right now is cost prohibitive, but maybe we can narrow this down to a set of 20 genes or 30 genes that are really account for 80% of the variability. If we can do that, then essentially you could combine histologic analysis with some sort of a, gene chip analysis that would allow us to enrich the population so that not just one, every pharmaceutical company can then in a precision of way, target the right population instead of trying to hit everybody and hoping that, someone will respond, somebody won't. Be able to, in a targeted way, find 90% plus response rates.
Thank you to the panel for the good discussion, stimulating answers to the questions, and we look forward to future studies and more results. So, and thank you all for being here.
Thank you to you for leading the meeting so well.
Oh, you're so kind. Thank you for being here and for the live.